Thank you very much. I first like to excuse Dr. Julien Nizaro, who already had to leave for France. So I would also like to thank all the speakers of Working Group 3. I think we had a very fruitful discussion. It was a very interactive session. So we are pleased to give you some main findings of all the presentations that we're giving and to do some recommendations. So one of the main findings was that indeed we have some red flags which are barriers for people to stay into the labor force or to reintegrate. So these system barriers, they give us some reason to really have a supportive policy. So this is really needed. So it's a good thing that also for EU work is one of the key issues to address the upcoming years together with the SIP. We came to the conclusion that vocational rehabilitation is not available for all EU citizens, and that also a modified, sustainable and healthy, inclusive workplace is not available for everybody. So as you can remember from systematic reviews, as we all know from Weddell and Borton, which showed us that work is very important for health, we really wanted to emphasize from the working group that good work is good for your health in a supportive environment, a work adapted to your own capacities and competences. And when we need to develop policy, we also have to pay attention that we need sustainable work. When we do studies in Belgium about reintegration, we are not interested in getting people back to work for 1 week, for example. We want them to get back into the labor force for a long period, forever if possible. We need some preventive reintegrative approach, which means that every stakeholder has to adapt his or her role. We are not used to act like that. Silos between health and work policies hinder the inclusion of pain patients, chronic pain patients into the workforce. We also came to the conclusion that we currently lack a patient-centered approach. One of the novelties that we came up to in the work group was, could it not be possible to give incentives for all parties involved that are aligned with patient goals? That means that, for example, if a patient wants to go back to work, that outcome measure must be a sustainable job and that incentives are given to all stakeholders when they reach that goal. We heard it in other presentations today. We still have a lot of health inequalities, also on the level of the pain management to go back to work. And we also wanted to highlight in that aspect the involvement of the primary care setting. In many European countries, the primary physician, the family practitioner, is really the point to start vocational rehabilitation. But for them, involvement in whole that process is often not a priority. And this has also to do with the way we're financing those stakeholders, because they are not financed to have, for example, in some countries, consultations about return to work, because it's not a consultation like you measure a blood pressure, etc. One of the presentations in which the patient approach was highlighted showed that it is very important when you work on pain management in relation to getting people back to work or letting people be able to retain their job, is having a life course approach. That means you cannot see people as human beings being in one moment of their life. Every decision that you take, every action that you have or that you want to take must be aligned with the whole life course. The next slide shows the last main findings. So it is very important that policy recognizes that those with chronic pain face multiple challenges. For example, the low incomes, the poor pensions, and this also could be drawbacks to have people to have the perception that people are less motivated to reintegrate into the labor force. But if we go deeper and when we assess what's really is an issue is, for example, the insecurity to lose your benefits, to go back to work, to again remain on sick leave, and having this situation makes that people are more insecure than when just having a diagnosis. Pain is also elevates the risk for mental illness. It was shown in one of the presentations that there is a close relationship association with anxiety and depression. So that really highlights the importance of an integrated biopsychosocial approach, which we concluded in the working group that everybody in Europe is talking about it. We also heard yesterday something about the ICD and the relationship with the ICF. So everybody, every stakeholder is now talking about implementing the ICF and integrative biopsychosocial point of view. But if you really look at it, we are not doing it. We are not really implementing it. So holistic care combining pharmacotherapy and functional restoration should be a patient right, because also we have a social obligation to guide patients towards realistic participation and professional reintegration. So I would like now to give the word to Britta, who will do the recommendations.
Thank you very much, Saskia. Now we come to the recommendations which are based on the main findings. So the European Commission should increase, do we have them? Yes, thank you. Should increase investment in pain research as a priority in future EU framework programs and undertake or promote research on presentism in voluntary causes of early retirement across Europe. The European Commission should promote and facilitate the exchange of good practices on pain and workability among all relevant stakeholders in member states to facilitate the reduction of health inequalities. The European Commission should promote national information campaigns. National governments should invest in technologies to prevent involuntary early retirement and allow workers that wish to continue participating in the workplace. National governments should appoint relevant national institutions, for example, cross-ministerial working groups, to build bridges between healthcare, employment, occupational safety, social protection and finance policy systems to improve the work participation of people with health-related challenges. With the right employer attitudes and workplace adjustments combined with support from public health systems, many people living with pain could continue working. National governments should invest in interventions which have work participation as an outcome in line with patients' goals, including early intervention. National governments should prioritize vocational rehabilitation, starting point with primary care, promoting focus on work capacity instead of disability. National governments should promote taking into account mental comorbidities, for example, through the promotion of health and well-being in the workforce. National plans should encourage enforcement of existing national legislation requiring reasonable, flexible workplace adjustments by employers that can help people with chronic diseases stay in work or reintegrate the workforce. National governments should develop chronic diseases, cost of illness studies, and cost effectiveness evaluations of interventions, including societal aspects beyond the direct costs on the health system, to support rational decision-making and cost-effective resource allocation. National government should provide coaching for and between all stakeholders, including employers and insurance companies in private and public sector. Thank you very much for your attention.